Thanks, Shelley.
Are
you recording us, Eric?
I'm recording so that we can later put this on the training portal for future training purposes. So hopefully everyone's had a chance also to log on via the WebEx, not just the phone call, because there's some great slides that Dr. Weinstein's going to show. So hopefully everybody's able to dial in as well as log on.
We have about 25 folks on the line, Eric.
Oh, fantastic. Okay, so we'll probably get started now. So first, obviously, I want to introduce myself. Everyone recognizes my voice, I'm sure, but Eric Savoy, your Invokana training manager. Also assisted here with Shelley Hillman, who is the Divisional Performance Excellence Manager as well. So I'm sitting here at St. Mike's Hospital with Dr. Jordan Weinstein, and obviously Dr. Weinstein is our guest host today as he's presenting us some slides. And the real purpose of today's WebEx, just like the one that on Tuesday, was just to kind of give you some further background information on Invokana and some of the things that are in our product monograph, as well as to set us up for success for future entrance into this category, and also for a successful regional cycle meeting that's going to happen in about 2 weeks' time for across the country. So we will be recording this session, as you probably heard me say before, and we will be hosting this on the training portal. That way people can access in the future, as well as for our LifeScan folks can be able to access and review the same training that you're getting as well. I can't stress enough that this training is for you. This is not for us, so it's for everyone on the line. So I want to make sure that it's interactive as possible, and feel free to ask Dr. Weinstein or myself or anybody on the line for additional questions or clarifications, because we want to make sure that you leave the meeting with more information than when you came. So feel free to ask questions and ask for clarifying. If you're afraid to ask a question, you want to remain anonymous, just send myself a quick IM, and then Shelley, I'm not logged on, so Shelley can just read out the question anonymously in case you don't feel like speaking up, but we want to make sure every question is answered. So with that, also as a quick reminder, if there's any background noise where you're at, I know that I've taken these calls from all across the, Starbucks and offices and everywhere else, so certainly feel free to mute yourself. I think it's *67. Or you can just mute your phone. So we'll get started now. So like I said, I'm here at St. Mike's with Dr. Jordan Weinstein, and he's a nephrologist here. And he's also assistant professor of medicine at the University of Toronto. His clinical interests are hypertension, end-stage renal disease, renal replacement therapy, and living donor kidney transplantation and kidney stones. This is the reason we're using him. He's a clinician teacher. He's completed a master teacher certification from the University of Toronto, and he teaches at all levels of medical and allied health education. So we're looking forward to having a great WebEx, and I will turn it over to Dr. Weinstein.
Great. Can everyone hear me? Because I'm just on a headset. I'm not sure if you can't respond, can you?
Yeah, it's loud and clear.
Oh, yeah. Loud and clear. Okay, great. And then the other thing I'm going to try and do is I'm going to just share a specific application for my desktop as opposed to my whole desktop, and I just want to make sure that comes through too. So is everyone seeing PowerPoint now?
Yeah. Yes.
Okay, great. Do you see anything else? Otherwise I'll have to close off all these windows that I have open, or do you just see PowerPoint?
Just PowerPoint.
Okay, sounds good. Okay, so thanks very much, everybody, for joining today. I think that I'm actually envious of where you are as a company because, or at least I'm in a congratulatory mode for you as a company, because I think that you're on the cusp of something very, very exciting in diabetes and potentially even beyond diabetes into chronic kidney disease management in general. So I think that you are the first in the world to be entering into this exciting field, very exciting field. So I think you've got really, really interesting and promising times ahead. But of course, with any new therapy, I guess there's always going to be questions, and as the rollout occurs, you're going to have responses back from your field force or from your clients or from physicians or from pharmacists. And I think it's important to understand how to respond to certain concerns because some of them are actually not concerns, some of them are overstated concerns, some of them are understated concerns. So I think it's just important to have a bit of a narrative around what's going on. And I hope as a physician I can give you some of my perspective on that. So I'm going to try and advance the slide here. Okay, so the agenda is as follows. We're going to cover several areas, and we're going to not necessarily do it in a complete linear fashion. In other words, we're going to come back to some of these topics at different points throughout the WebEx. So we'll see some of these themes spoken of at different points in time throughout the presentation. Of course, this is the focus of what we're talking about today, which is the renal handling of glucose. This is where it all starts. When I say this all starts, meaning some of the questions that come up, all begins at this diagram here, which is the mode of action for, or the target for the new therapy that we're discussing, and understanding what is going on at this level might help us understand some of the concerns that have come up and potentially how to explain them. So the glomerulus, for those of you who aren't familiar with renal anatomy, the glomerulus is the top of, or the initial segment of something known as the nephron, which is the main filtering unit of the kidney. There are about 1 million nephrons in each kidney. You are born and die with you're born with your maximum number and die with less, so they never replicate over time. You can only have less glomeruli over time, not more. Some of them can actually grow in size, but they never grow in number. The glomerulus is the main filtering site. It's where the initial urinary filtrate appears. So it's where the unprocessed, this is in one form, you can think of this is urine that still has to be refined over many different segments of the nephron before it becomes what ultimately goes into the sewer. But what appears in the proximal tubule, the first urinary filtrate, and what ends up coming out as final urine, they're very, very different. So a lot is processed, added, subtracted to and from the urine to make it the final urinary product. So one of the things that gets filtered at the level of the glomerulus, like any small molecule would, is glucose. And around 180 grams of glucose gets filtered. What that means is it gets squeezed through special pores in the glomerulus to ultimately appear in the urine. And it enters the proximal tubule, makes its way down the loop of Henle, the distal tubule, and if enough of it is present, or if mechanisms are not in place to take it back, then some of it will appear in the urine.
Dr. Weinstein, sorry,
to interrupt.
can't see
Are
your
you
diagram.
showing a diagram?
Sorry, you don't see a diagram?
No,
I see
right now on my
now. We did not see the previous slide though, but I see that. Is that all that you have on your screen?
I just see the post-reabsorption arrow, and that's it.
Oh, that's strange. How about now?
It's almost like half the slides are cut off.
Yes.
Half the slides are
Sorry
cut
to
off.
interrupt.
Okay, let me try something else here. Let me share a slightly different way here. Just one sec, okay?
Thank you.
I can actually try and share my entire screen as opposed to just that application. So just one second. What do you see now?
Yeah, now we can see the whole slide.
Now see the whole thing?
Yes.
Okay, great.
Thank you. Sorry about that.
No problem. So again, you get filtration of the glucose level of the glomerulus, and then if it weren't for absorbing mechanisms that were present in the kidney, you would have all that glucose pass straight into the toilet, as it were. So there are obviously mechanisms in place to take that glucose back. Why are there mechanisms to take it back? Why don't you just let it all disappear into the urine? Because we were designed to conserve calories for periods of time when calories were not plentiful. So it makes a lot of sense, actually, that if you're going to spill glucose into the urine, and glucose is ultimately an energy source, and energy is not always available in a cupboard, because remember, we were designed to live in caves to survive droughts and famines and things like that. There has to be mechanisms in place to prevent the kidney from wasting what is ultimately a precious energy source. And so there's a highly conserved system to reabsorb glucose out of the urine, and it is attributed to the two major transporters, SGLT2 and SGLT1. SGLT2 is the main actor here because it absorbs 90% of the filtered glucose, whereas the rest, only 10% that is reabsorbed by SGLT1. SGLT2 is also uniquely a renal transporter. It's not really present anywhere else, unlike SGLT1. So this is a highly specific site of action for glucose reabsorption, and it's targetable in an attractive way because there are no other areas in the body really where SGLT2 functions. So this is how it happens that glucose is filtered so avidly or so easily, and yet none of it, for the most part, ends up in the urine because of the function of these transporter systems. So ultimately, if everything is working, or if there's working meaning there's a capacity to reabsorb all this glucose, you won't see any glucose in the urine, even if there's quite a bit of it. These transporters can actually accommodate, increase their function, as we'll see, and for the most part, you should never see glucose in the urine unless certain conditions are met, which we'll come to. Now imagine if, for example, you had an excess amount of glucose. What would the story be there? Well, you do get increased expression of SGLT2 and SGLT1, so that if you increase glucose excretion or filtration at the level of the glomerulus, you actually accommodate by reabsorbing more of it, which makes sense, again, because if the kidney's purpose is to maintain or retain things for the body that have value, and if it sees more glucose, it should respond by reabsorbing more glucose. Remember that the kidney is not designed to think of disease. It's not designed to think of, well, what would happen if you were diabetic? All the kidney really is programmed to do is respond to an increased load of glucose, not why you have an increased load of glucose. And so for the most part, if patients have an increased glucose load in the proximal tubule over time, SGLT2 and SGLT1 transporter expression will increase. And that means that the capacity to absorb glucose in the kidney increases as increased glucose delivery occurs. And it makes sense, as we talked about, the animal that I think we understand best in terms of the conservationalist would be the camel. So the camel actually has a highly efficient kidney, but not so much from the point of view of glucose absorption, but for water absorption. So the camel can actually excrete an extremely tiny volume of urine, not as small actually as the desert mouse, which has the smallest urinary excretion per unit body weight in the world. The desert mouse and the camel live in the same environment. But basically, these animals are highly conserved to reabsorb all the water out of the kidney as is possible within reason. The kidney of humans is also conserved to reabsorb water. We obviously can concentrate our urine when we need to. But we also have this additional, I'm not sure it's unique to humans. The slide is a little misleading. Not unique to humans, but one of the things additionally that the kidney is famous for in humans, as we'll talk about today, and we have already, is that it conserves glucose as well. So the kidney is not only an organ that can remove toxins, but also retain things that it needs to when it needs to retain it. I think all of you have seen this cartoon before. It's probably the most famous PowerPoint-produced cartoon in the history of pharmaceutical sales. Probably this is the SGLT2 inhibition cartoon, basically. So it works like this. So if a patient who on the left has type 2 diabetes, remember that a patient with diabetes, the hallmark would be hyperglycemia. They're going to deliver more glucose to the kidney. That kidney is going to respond, accommodate by increasing its SGLT2 expression, which means that a patient with diabetes is going to have an increased capacity to reabsorb glucose out of the urine and put it back into the blood space, which means also that the diabetic kidney in some ways is involved in maintaining hyperglycemia when really it shouldn't. But again, it's because the kidney was flogged into reabsorbing more glucose and putting it back into the blood space. So in a patient with diabetes on the left, provided that the SGLT2 system is working, and it almost always does, they can get their renal threshold, as it's called, for glucose up to as high as 14 millimoles per liter, which means that if your blood glucose is below 14 millimoles per liter, all of that glucose can be reabsorbed by the kidney. For people without diabetes, the renal threshold for glucose is going to be lower because they don't have this amped up SGLT2 expression. And so patients without diabetes, the RTG will be closer to around 11 millimoles per liter. Now, this therefore makes blockading this transporter system extremely attractive, because if the kidney is involved in sustaining hyperglycemia, and hyperglycemia is the hallmark of diabetes, then why don't we stop the kidney, or at least limit the kidney's absorption? And stop is not a good word. Limit the kidney's absorption of glucose. Put them back in a absorbing capacity that's closer to what they were without diabetes. But of course, they're still going to have hyperglycemia. So what this means is you have a high blood sugar, and now less capacity to reabsorb glucose than the average person with diabetes when you have an inhibitor on board. And the end result is what you see on the right, is that instead of glucose being absorbed up to 14 millimoles per liter, only up to about 5 millimoles per liter is absorbed, and the difference, if your blood sugar was 14, would end up in the urine. And that is the source of glucose exit from the body. This is important for a couple of reasons, not only because it explains, this diagram that is, not only does it explain how the drug works, but it also will tell you when the drug will stop working. And when I mean stop working, I don't mean ineffective. I mean it will self-regulate. In other words, if the blood sugar falls below 5 millimoles per liter, say down to 4, well, the kidney's ability to reabsorb glucose is still intact up to 5 millimoles per liter. So that means that provided that the blood sugar is not above 5, the glucose will not spill out from the kidney. So if you develop hypoglycemia, you will not, from other causes, let's say because you were given a big dose of insulin or something like that, the kidney will no longer spill glucose. So the kidney, or the SGLT2 inhibited kidney, cannot be blamed, so to speak, when patients develop hypoglycemia, because it's not the source of the glucose loss at that point. The kidney's ability to absorb glucose will be intact. Just it won't be as high capacity as it was before the inhibitor was on board. So that's a really important point, because SGLT2 inhibitors then should not and do not directly contribute to hypoglycemia. But of course, if other drugs are on board that do, like insulin or sulfonylureas, then yes, you can get more hypoglycemia, but in and of itself, the SGLT2 inhibitor class does not cause hypoglycemia for that reason. And this is the same idea, but in a graphic format. So if you look on the x-axis here, you've probably seen these slides in different forms. You have the plasma glucose, and that's in blood on the x-axis, and then on the y-axis is what is the corresponding glucose excretion for each level of plasma glucose. So as you can see on the bottom, as you increase plasma glucose 2, 4, 6, 8 millimole per liter, up to 10 in healthy people, or 11 depending on the literature you read, when you have glucose levels in the blood up to those levels, all of it can be reabsorbed at the kidney level because of SGLT2. After you exceed the kidney's ability to reabsorb glucose, you reached what's known as the threshold, or the RTG, the renal threshold for glucose. Now, as you increase plasma glucose, urinary glucose will rise, and as you can see here, it rises in a linear way. Patients with diabetes, that increase in urinary glucose does not happen until later, because they have a higher capacity due to the increased SGLT2 expression. All you do when you put patients on an inhibitor is shift their curve back down towards where they were before, and below, in fact. So below the 10 that they were at in health, but far below the 14 that they were at with diabetes, and closer to, let's say, 5 or 6. That actual number, what the threshold is when inhibited, is variable, but it gives you an idea of what the threshold will be. It's certainly not 0, and it's probably not 10. It's somewhere in between. I'm just taking a sip of my beverage, just one moment. Okay, so this is the urinary glucose excretion, UGE, which is, to be quite honest with you, a term that you're going to hear a lot of, but it's never really been a term that was used before. It's really a term that has rose to prominence because of SGLT2 inhibitors, frankly. This is not something that nephrologists talk about on a regular basis, because it's really not that important. We know that urinary glucose happens when there is hyperglycemia, or sometimes when transporters for glucose absorption are broken, such as in patients with renal glycosuria, which is a benign condition where you spill glucose in the urine at normal blood concentrations. But this concept of UGE has risen to prominence now because it is a method to control glycemia in patients with diabetes. So under normal circumstances, the kidney can absorb all of the glucose, 180, and when SGLT2 and 1 are functioning, they can ensure that less than half a gram a day is excreted in the urine of healthy adults, and oftentimes it's far less than half a gram. It's down to 0, in fact. And so glycosuria is always caused by elevated blood glucose, usually due to untreated diabetes, or I say nearly always, and in a minority of cases in patients who have this very rare but well-described transporter defect where it's almost like they have an SGLT2 inhibitor on board at all times. But again, these are patients who do not have diabetes and actually, importantly, do not have any renal disease of any kind. They just spill glucose into their urine, and it doesn't seem to be associated with any adverse effects to them at all. In fact, they never really come to medical attention unless someone does a dipstick on them for whatever reason, find them to be having glucose there, but they don't have anything else wrong with them, and they never develop anything else. So in terms of Invokana and the urinary glucose excretion, it will induce a UGE that's higher than normal, far higher than normal. So if normally you're at half a gram, well, with Invokana on board and hyperglycemia present, you're going to see a variable UGE of 77 to 119 grams per day. This is a number that you should interpret with a huge grain of sugar, I guess, or salt, and that's because you're not going to excrete any urinary glucose, even if you take Invokana, if your blood glucose is low. So as diabetics improve their blood sugar, or if they develop a hypo, or if, let's say, they're low for an entire day, their UGE for that day is going to be 0 because they're going to be below the threshold to reabsorb it. So these numbers of what you're going to see in terms of UGE on Invokana, you really have to interpret with a grain of salt because they're highly variable depending on the patient, and even within each patient, you're going to have variability from day to day. But because you periodically or often will lose glucose in the urine to varying degrees, you're going to lose calories into the urine. It's like the opposite of eating. You're literally in calorie wasting mode. You're not burning them, you're wasting them. You're literally excreting them. They go from the mouth to the urine, which is a pathway that didn't really exist before, at least that we can modify with drugs until this drug class came out. And as it works out, depending on your glucose excretion, that's obviously going to depend on your calorie excretion, but you can expect, or patients can expect, to lose between 308 and 476 kilocalories per day due to this loss of UGE. What does that translate into, or what does that work out to food-wise? So, I mean, I've used this analogy before because I famously love the Wonder Bar chocolate bar, but a Wonder Bar is about 300 calories. So a good full-size chocolate bar, not like the little Halloween ones, but the full-size chocolate bars are around 300 calories or so. So depending on your UGE, you're able to excrete 1 to 1.5 Wonder Bars a day, which means you can eat 1 to 1.5 Wonder Bars a day, theoretically, I'm not advocating it, and not be in positive calorie balance if this drug was on board. But that's just to give you an analogy, not to recommend this to patients, of course. And just to that point, in all seriousness, when patients, remember that in the studies that looked at weight loss with Invokana, the patients didn't know they were on this medication. They could have been on a placebo. And so if patients are put on this medication, know they're on this medication, there is the possibility that they will eat more because they feel that they can account for it by losing it in the urine. And so I almost wondered whether this drug could paradoxically cause weight gain. But of course it doesn't, at least in the clinical studies. But it might be something to be mindful of in our clinical practice, because it's kind of like that analogy, actually not analogy, that data that shows that patients who drink sugar-free beverages, so people who drink Diet Coke, generally speaking, eat more calories per day than people who don't drink Diet Coke. And part of the reason for that is they feel that if they've made up for it with their Diet Coke, they can eat elsewhere, and they don't overcompensate. They do the math wrong. So they figure, well, I'm not going to have the 200-300 calories from my Coke, but I'll have a 700-calorie cupcake. And so could this happen with Invokana? I don't know, but it's something to be aware of if, for example, patients don't lose the weight that they thought that they were going to lose. What would be the impact of blockading a drug or a system, a transporter system that reabsorbs glucose and causes calorie loss? Well, the obvious one is that you're going to reduce glycemia and improve A1C without really precipitating hypoglycemia. That's true of Invokana and drugs like it. The other thing that is perhaps underappreciated when this drug was first being developed, but I think has really risen to prominence in a good and bad way, is that these drugs can also lower blood pressure. It's a good thing if you want your blood pressure to fall, and 75% of diabetics have hypertension, although not 75% of diabetics have hypertension. So in other words, not all diabetics want to lose blood pressure or decrease their blood pressure. And certainly if you don't have hypertension, dropping your blood pressure could be viewed as an adverse effect. And as you probably know, in the monographs, the blood pressure lowering is actually considered to some extent to be an adverse event. It's not considered to be a positive property of this drug. I believe it is. I don't know if that's considered off-label. I believe that it's a very interesting property of this drug, and it can be used, if used properly, it can be integrated into the antihypertensive regimen of a patient. But technically speaking, drop in blood pressure is considered to some to be, or to many, to be an adverse event, or at least an event you have to be mindful of and cautious of. And the effect of it, the magnitude of it, is somewhere along the line of 5 millimeters of mercury, which is similar to being on a thiazide diuretic. More on that later. And of course, we have the weight loss, which we discussed. I'm going to turn to hypertension now, only because hypertension is intertwined with this medication, both in terms of the efficacy and the adverse effects of the drug, and to some of the concerns that have arisen, that invariably do for all drugs, but with this drug. Diabetes is a condition that is not just hyperglycemia. It's obviously hyperglycemia is the root of it, but it's much more than that. And if you want to interpret it as the full experience of the patient, unfortunately, it's much more than hyperglycemia. It's the end organs that get damaged. And so the hallmarks of glycemia and dysglycemia in patients with diabetes are the complications they get, namely the big ones anyway: myocardial infarction, stroke, limb loss, end-stage renal disease. So these are the big ticket items when it comes to patients with diabetes. Good news, bad news. The bad news is a sort of precipitous rise in the incidence and prevalence of diabetes, certainly the prevalence. What that means then, of course, is that there's going to be a huge prevalence of diabetic complications. However, on a sort of per patient level, or per thousand or per 10,000 patients, the incidence of these complications has declined. So in other words, patients' risk of developing a complication related to diabetes has decreased over time because we've gotten much better at managing it. But of course, there's still an enormous number of these complications and an enormous number of patients, and so we should not be lulled into any complacency at all, because even though they're less frequent per patient than they used to be, there's so many more patients than there used to be. So we still see an awful lot of this. The end-stage renal disease one is interesting because of course, it's my neck of the woods, but the end-stage renal disease piece has not really declined as much as some of the others, like stroke and MI have. So the impact on end-stage renal disease in patients with diabetes, managing diabetes, has not really gone down as much as we had hoped. And that could be because there's much more to end-stage renal disease in patients with diabetes than just glycemia. There's blood pressure, there's lipids, there's many things that could go into it, like with the other conditions. But it seems that the kidney is far more sensitive, perhaps, than some of the other end organs or other organ systems that are complicated by diabetes. Now, when it comes to hypertension has morphed completely over the past even 15, 20 years. So when I started my career around 12 years ago, I used to give a talk on hypertension, and I used to talk about the control rates of hypertension in the United States. And at that time, I still have the slide, 2/3 of patients in the United States did not have blood pressure at target, and 1/3 were at target. Well, now in Ontario specifically, in Canada too, but in Ontario specifically, it's the exact inverse. So 2/3 of patients with hypertension are meeting their hypertension goal, except in patients with diabetes. And in patients with diabetes, you're going to see different numbers, but anywhere between half to 2/3 of patients would not technically meet the blood pressure target for diabetes. Now, just because you don't get people to blood pressure goal does not mean that you should give up. First, because you could always get them to goal eventually, and also because you do get part marks in hypertension. So it's been estimated that for each 2 millimeters of mercury that you reduce systolic blood pressure, you get substantial reductions in mortality related to cardiovascular disease, specifically coronary disease, and the biggest one always is going to be reduction in stroke for just 2 millimeters of mercury. Now, those statistics which get bandied about a lot are very misleading because it's not every 2 millimeters of mercury. What they do is they take the total amount of blood pressure reduction and the total reduction in stroke and basically divide one by the other, and you get a percentage per millimeter of mercury. But not all millimeters of mercury are created equal. In other words, the most dangerous ones are going to be the much higher levels of hypertension. If someone is 2 millimeters of mercury above their blood pressure target, you lower them by 2, you're not going to decrease their stroke mortality by 10%. So it's a bit of a misleading number, but just to make the point that each little bit does help. And physiology of blood pressure, can't go into this in too much detail, but it matters for one reason that we'll come to when we discuss some of the concern around one subgroup of patients who are on SGLT2 inhibitors. Blood pressure, remember, is basically the pressure within the blood vessel that's measurable externally. It's the pressure exerted by the force and flow of blood through the blood vessels. Well, what's going to determine what that pressure or that force per unit area, which is pressure, what that pressure actually is? What are the determinants of it? Well, if you have blood moving through a blood vessel at a certain rate, and then you constrict the blood vessel and you try and maintain the same flow through that blood vessel, you're going to increase pressure upstream from the blood vessel itself. So in other words, within that blood vessel, you may not get in that blood vessel that's constricted, you might not get higher pressure, but that will shunt blood away from it into the rest of the body, and those vessels will experience higher blood pressure. So these are what's known as the capacitance vessels, and when they're constricted, they create hypertension and high pressure within the central vessels and then some of the smaller vessels. And that barotrauma, that increased pressure in the vessel itself, can create a barotrauma that actually causes damage, and combined with things like smoking, hyperglycemia, and hyperlipidemia, can lead to atheroma and to atherosclerosis and to damage of the blood vessels in any vascular bed, whether it's the brain, the heart, the kidney. Now, the brain is particularly sensitive to hypertensive damage, but the heart is also, as is the kidney. Now, how could you reduce blood pressure? Well, in many ways. You can either relax the blood vessels, decrease the resistance, and therefore decrease blood pressure, or you can decrease the amount of blood that is flowing through the vessels themselves. So you can increase the container size or decrease what the container is containing. And so, for example, diuretics, which decrease plasma water, might decrease the amount of blood volume that needs to be pumped, and therefore, even irrespective of the compartment size, you're going to have a lower amount of pressure. And I think that you can draw many analogies in life, whether it's garden hoses or things like that. If you reduce the total amount of blood to be pumped, you can reduce the pressure overall. So it's a resistance issue and it's a volume issue. There's other determinants as well, of course, but those are some of the big ones. When it comes to how we lower blood pressure, we are lucky in Canada, and I guess the rest of the world benefits too, because of the Canadian Hypertension Education Program, or the CHEP program. And every year the CHEP group meets and they publish their latest guidelines, which are now iterative, so they just add to their existing guidelines of how to manage hypertension, which is manage is a big term. In other words, or it's an all-encompassing term. It's how you diagnose, how you treat. And when you treat, it's how you treat with pharmacologic and non-pharmacologic agents. So the CHEP guidelines are very, very important guideline set, probably the best set of hypertension guidelines in the world. They're very detailed. The 2014 guidelines, they reiterated, of course, the things from previous guidelines that are still valid, which are, of course, patients with diabetes are at high cardiovascular risk. Most patients with diabetes, about 2/3, have hypertension, and some say up to 3/4. Treatment of hypertension has major impact on basically all major organ systems. Treating hypertension in patients with diabetes reduces death and disability and healthcare costs. And, you know, sometimes it's sad in many ways when patients come to my office and they're addressing everything except their blood pressure. And the reason it's sad is because it's probably the most dangerous thing to them. It's actually probably more dangerous than diabetes itself. The impact of treating blood pressure is greater than the impact of treating glycemia in patients with type 2 diabetes. There's very good data for that. Yet the world seems much more focused on glycemic control than on blood pressure control. The tragedy of it is, of course, that a stroke, which is the most feared and predictable outcome of hypertension, actually is completely preventable, but also totally devastating if you don't prevent it. So it's a bit of a tragic story there, and why nephrologists are very, very intense on lowering blood pressure, because we know how to do it, and we know that when we do it, it has enormous impact. In patients with diabetes, it's one of the only groups that has a lower blood pressure target than other groups. That is a 130 on 80. The rest of the groups, with some exceptions, are 140 on 90. And the other thing that they reiterated in the 2014 guidelines is that using ACE inhibitors and angiotensin blockers together in the same patient should be avoided. That was sort of a top-level summary of the CHEP 2014 guidelines. Of course, there's much more data or information in the guidelines from previous years that are still relevant. So, for example, this one is the main diabetes slide, which basically says that if patients are over 130 on 80, they should be targeted to under 130 on 80, whether they have nephropathy or not nephropathy, which by CHEP is really defined as having protein in your urine or not with diabetes. It's actually one of the few things with CHEP that I really don't like, which is that they define patients with diabetes as nephropathy and not nephropathy. I treat all patients with diabetes, whether they have nephropathy or not, the same. The other thing I don't like about CHEP's slide here is that they define nephropathy as having proteinuria, and if you don't have proteinuria, you don't have nephropathy. Well, that's really overly simplistic, because many patients with diabetes do not have proteinuria, but very significant reductions in renal function. So you wouldn't say that they don't have some type of kidney problem. What CHEP recommends is that if you have a patient over 130 on 80 with diabetes, you start treating them. If they're well above their target, like 20 over 10 above target, you actually should start treating them, potentially consider treating them with 2 drugs to start as opposed to 1 drug and then waiting for its effect. But not all people do this. These are the different blood pressure targets we have. The one we're going to focus on a lot, of course, is diabetes, which is 130/80. Everyone else is 140 on 90. So that's hypertension in the context of MI, previous stroke. Even kidney disease, actually, the target is 140 on 90, unless your kidney disease is in the context of diabetes. There are some other special groups that have received attention by CHEP recently. One is the low-risk group, which I don't really follow. So the low-risk group, I don't follow this recommendation, which basically states if you have a young patient, let's say a 35 or 42-year-old, something young like that, a patient who's young like that with absolutely no other risk factors for coronary disease or cardiovascular disease, and all they have is hypertension, you've ruled out strange causes for hypertension, you could argue that those patients don't need to be treated unless their blood pressure exceeded 160 on 100, because if you do various calculations on them, you'll find that the added risk to them of the 160 on 100 is very minimal and does not justify treatment. I personally don't do that. I treat all patients, young and old, the same. Well, I'm not going to get into why. It's just a bias of mine, but I treat even patients at low risk to 140 on 90 or less. And the very elderly also received attention for the first time a few years ago. Now they have their own indication for hypertension management, and that is if they are at a 160 or greater, then you should target them for lowering, but you don't have to be as strict potentially as you do with other patients. And if you're over 80, that's what very elderly means, then you can target 150 over 90 or less as opposed to 140. So the treatments. The CHEP guidelines go through a variety of different treatment slides depending on the patient you have. This is the famous slide that refers to the uncomplicated hypertension patient, which means a patient who has nothing else wrong with them besides hypertension. So for those patients, the target is 140 on 90 or less. Lifestyle modifications first and always, or intercurrent with medication. And then you have 5 options to choose from, which are listed in the 5 boxes there. Once again, CHEP recommends 2 drugs if they're well above target. Not all people do that. The reason is that the blood pressure that they have in the office when they see you may not be their true blood pressure, and so maybe you're over-treating some patients. So I rarely start at with 2 drugs. I'm a little bit more cautious, but I'll bring them back sooner and verify the effect. Beta blockers get a bit of a bad rap in the uncomplicated patient if they're over age 60, because the stroke prevention of beta blockers for the same blood pressure drop that you get with them was disappointing in a lot of studies. So if you have a patient who's over age 60 and they have no other indication for hypertension management, then you should pick a drug besides a beta blocker. Not all people believe that recommendation, but many still do. Some more notes from the CHEP guidelines suggest that you should use caution when initiating 2 drugs, which is sort of strange because they're the ones advocating to use 2 drugs in patients, but they do suggest that if you're going to use 2 drugs, to do so cautiously. Now, this is something that is extremely important to this whole story of SGLT2 inhibitors, because if you remember what I was saying before, that these drugs, this class of SGLT2 inhibitors is in fact a mild diuretic. It is in fact an antihypertensive drug, and they're already on another antihypertensive drug, then you should consider that patient as being on 2 antihypertensive drugs. And if they're prone to hypotension, that would be the frail elderly, those with postural hypertension, those who are dehydrated, to use caution when initiating 2 drugs. So this story of this awareness of using multiple drugs to treat blood pressure, or that treat blood pressure, and adverse events, even though it could be a good thing to lower their blood pressure, has been known long before SGLT2 inhibitors came to market. So just bear that in mind as we move through this discussion. This is an issue that's well known. In particular, when you use ACE inhibitors and ARBs in combination with diuretics, you should be ultra cautious, because that combination is an extremely potent way of lowering blood pressure. Remember that every single ACE inhibitor and ARB in the world today, every single one of them, and there are 7, almost 8 if you consider one that never really happened in Canada, almost 9 because one went off the market. There were 9 at one point ARBs, now there's really about 7 ARBs. There are 2 still name brand ACE inhibitors, and if you count the off-patent drug ACE inhibitors, you'd have like another, I don't know, 8 or 9. So those 17 or so ACE inhibitor and ARBs, what do they all have in common? Every single one of those drugs comes with a fixed dose combination pill with hydrochlorothiazide. Also, with a few of them have CCBs, but every single one of them are packaged with a diuretic if you want them to be. And the reason is because combining an ACE and an ARB with a diuretic is the most potent way we know of in combination therapy to lower blood pressure. With certain ARBs, putting a diuretic on board with them, if you escalate the dose of each, the ARB and the diuretic, can lower blood pressure by 30 to 40 millimeters of mercury. So this awareness, this knowledge that adding a diuretic to an ACE inhibitor can cause hypotension or good blood pressure control, depending on your perspective, is extremely well known and should come as no surprise to anybody. Again, this will have relevance when we talk about some of the concerns in certain populations when put on SGLT2 inhibitors. The beta blocker note is there for patients over 60. They also recommend avoiding hypokalemia when you can, because potassium deficiency has been associated with worse cardiovascular outcomes. A paper in the New England Journal just last week pointed that out. You should never use ACE inhibitors and ARBs together. And patients who are Black, you shouldn't use ACE inhibitors as monotherapy unless they had a specific reason for it. And again, that comes from studies that suggest that ACE inhibitors work a little bit differently in patients who are of Black African descent. How do you treat hypertension? In stepwise fashion, you're supposed to start them on one drug and then add on drugs as you need to reach blood pressure goal. We don't have great guidelines to tell us what you add, but we have from experience some regimens that we know work well. The one that I mentioned before that we know works extremely well from a blood pressure lowering perspective is diuretics added on to vasodilating drugs like ACEs and ARBs. And the average patient needs 3 to 4 medications to reach their blood pressure goal. So you're going to see a lot of blood pressure drugs in patients once they've had a diagnosis of hypertension or met the criteria for a diagnosis of hypertension. I'm just going to skip over this because I sort of said it. ACE inhibitors. Very quickly, what are ACE inhibitors? They are probably the most important antihypertensive class we have. They are drugs that block the angiotensin-converting enzyme, and angiotensin-converting enzyme is important in the ultimate development of a hormone called angiotensin II, which, as the name angiotensin implies, is a drug that causes it's a hormone that causes vasoconstriction, one of the most potent hormones we have, and so inhibiting its production is a way of lowering blood pressure. ARBs are the cousin to ACE inhibitors. They work in the same pathway, but instead of blocking angiotensin II formation, they block angiotensin II receptor binding, and they came into being 10 years or so after the ACE inhibitor class did. Extremely great drugs in that they lower blood pressure well, and the one thing they do better than, or I don't say do better, the one thing that they have over ACE inhibitors is they don't cause cough to the extent that ACE inhibitors do. However, ACE inhibitors have better and more data in terms of end organ protection in the cardiovascular world than ARBs do. So here's just a quick diagram. The end hormone of interest here is angiotensin II because it does all sorts of things. Some of them quite nasty. And if you have lots of Ang2 on board, you can have all sorts of effects on vasoconstriction and sodium and water retention and cell growth and organ remodeling. So blocking Ang2 is a good thing in many cases, and you can either do it at the converting enzyme level or at the receptor level. Loop diuretics. So if you recall that cartoon of the kidney where the SGLT2 inhibitors worked, the SGLT2 inhibitors work in the proximal tubule, but further along the nephron as you enter into that loop, what's so-called loop of Henle, where much of the salt and water in the body is, or at least salt for sure, is absorbed. Loop diuretics work to block the reabsorption of sodium chloride and to some extent potassium in the thick ascending limb of the kidney, and blocking that loop of Henle with those diuretics is a potent way of causing salt and water to escape into the urine, and that's how loop diuretics act as antihypertensives and edema control agents. Thiazide diuretics work more distally down the kidney. They're not as potent as loop diuretics are, and as a result, loop diuretics are more potent all the time, and especially in patients with chronic kidney disease when hydrochlorothiazide and drugs like hydrochlorothiazide lose its potency. So what are some of the effects of ACEs and ARBs on the kidney and on volume itself? Well, we would need 7 hours of WebExes to go over the renal data for ACE inhibitors and ARBs, but for the most part, they work in extremely important ways, both ACEs and ARBs do, when it comes to the kidney. First and foremost, or you could start wherever you like, but one of the major functions of the ACE and ARB class is they reduce proteinuria. And by reducing proteinuria, it either reflects healing of the glomerulus, which is leaking protein, or by decreasing the amount of protein that gets leaked into the distal nephron, it causes less damage to the distal nephron, and so the ACE and ARB class can be viewed as renal protective because they specifically lower protein leakage into the urine, and ultimately down the road protect renal function is what we really want to do. And so if you look at this study, which is the most important study that we have, but there's 2 very similar to this study actually, or one other similar to this study. This is from the RENAL study. This is why we use ARBs to the extent that we do in nephrology. Showed that if you put patients on an ARB versus other drugs, despite having the same blood pressure control rate, you have a 20% reduction in major endpoints of, if you combine end-stage renal disease, doubling of creatinine, and death. So in other words, you combine all those outcomes together and you get a 20% improvement just by being on an angiotensin receptor blocker, and then it was independent of any difference in blood pressure. So there's something specific about the angiotensin receptor blocker class and ACE inhibitor class that protect the kidney. And that when I say protect the kidney, I don't mean just reducing proteinuria. I don't mean short-term changes in GFR. I mean the big one, which is preventing the kidney from failing. That's the best determinant of renal protection or renal damage. It's very difficult to look at a 6-week study or a 12-week study and change in creatinine and decide if a drug is being toxic to the kidney or not. What you have to do is a 4 or 5-year study and look at the rates of the kidney failing completely. So if you do that in this study here, bottom left panel, after 4 years, you start to see that we're not talking about creatinine changes here. We're not talking about proteinuria here. We're talking about patients having or not having to get a kidney transplant or go to the dialysis unit. You can't beat that outcome. The only thing better than that in the nephrology world is death. So if you want to talk renal protection, the only way to prove it, or the only way to show renal damage or renal protection, is to do a study that shows reductions in end-stage renal disease. The only other thing that comes close is doubling of creatinine. Not short-term, statistically significant changes in creatinine, but doubling of creatinine. Because, you know, going from a creatinine of 100 to 120 is significant, but it may not matter if it never goes above 120 again. But if it goes from 100 to 200, now we're talking very significant changes, now 100% change. So doubling of creatinine we accept as another marker of renal damage that is probably very significant, but not nearly as significant as end-stage renal disease. Now, putting patients, though, that was on the ARB class, very similar story in the ACE inhibitor class. This is one of many studies I could show you. I don't know why I picked this one, but so it is. This just basically shows you what happens to patients who are controls, let's say with diabetes, and patients who are put on ACE inhibitors. What you can see here is in the early part, this is only a year study, but in the first 6 months, you have pretty much no change in the GFR of the patients. If anything, the patients who are on ramipril had slightly lower GFR than patients who are in the control group, which makes sense because we know that ramipril will reduce glomerular pressure and therefore will cause a slight reduction in glomerular function, which sounds like a bad thing. But actually over time, the slight reduction in glomerular function will lead to less likelihood of the nephrons actually burning out. So many people get confused by this because we show that when you put a patient on an ACE or ARB, their creatinine goes up, their renal function goes down. So shouldn't that be a bad thing? Yes, it's a bad thing if you've got continuing loss of renal function to the point that you went on dialysis. Well, that would be awful. But what happens in these patients who are put on ACEs and ARBs is they get an initial loss of renal function, but over time, a preservation of the remaining amount of renal function so that in the end, you actually have far better long-term renal outcomes. And this is exactly why you can't judge the effect of a medication based on short-term studies, because if you looked at ramipril in a 6-month study, you'd think that these drugs cause renal failure because they do cause a slight reduction in GFR, but in the long run, they're protected. And the analogy that you could use, and you can use it in any profession, can use it in any way. If you want to say like a doctor, if a doctor saw 100 patients a day when he started his career, which is a lot, I see far less. So if a doctor saw 100 patients a day in the beginning of his career, that doctor would be highly productive in the first several years of his career if you multiply the number of patients by the number of days that he works. But I can guarantee you that he or she will burn out by about year 5 and see no further patients for the rest of their career. If that doctor was more like me and took it easy, saw fewer patients per day, he'll be able or she'll be able to work much longer into their career. And then that actually is a real analogy for what's happening at the glomerular level for sure. So you cannot judge renal protection or renal failure or renal harm based on short-term results unless the short-term results are very dramatic. Now, when it comes to SGLT2 inhibitors, that was a long lead-in to what we see with canagliflozin. So if you see here, you can see that these curves look very similar to the previous set of curves, that you have a baseline and then you have GFR, just like this curve here. You have baseline and then you have GFR and then GFR over time changing. Well, that's what we have here. We have baseline and then GFR changing over time. But if you look carefully, this is a 26-week study. This is a very short study. This is 6 months or so. What is happening? Well, when you put patients on canagliflozin in teal and orange, in red and black, these patients will have a short-term early drop in their GFR. The reason for that is because they lose salt and water, blood volume goes down, blood pressure might go down, GFR goes down. Importantly, though, over the course of the next 26 weeks or the next 20 weeks of the 26-week study, the GFR recovers towards where they started so that the net loss of GFR is not much below what they, below, let's say, 2-3 mils per minute. This is very, very tiny changes in GFR, and it's only slightly worse, and I use the word worse in quotes, worse than placebo. I say that worse could actually not be bad because a short-term loss in GFR may be good. It may be protective against the kidney, or for the kidney, just like ACE inhibitors, the short-term drop in GFR is protective of the kidney. What we don't know is what happens not 26 weeks in, but 200 weeks in, or maybe not quite that far, but 5 years in, 4 to 5 years in. The question of renal survival can only be answered when you look at outcomes like doubling of creatinine or ESRD, which this study does not come close to doing. When it comes to some of the precautions that we see in Invokana's product monograph and some of the things that maybe your competition might be talking about to bash the product, which could happen from time to time, it's a bit of misinformation. And I think that once we look at Invokana in the context of drugs that we already use, it should come as no surprise why some of these warnings appear as they are. I think that they can be explained very simply. So what you see in the product monograph is, first, Invokana increases urinary glucose excretion and induces an osmotic diuresis, which may reduce intravascular volume. This is identical if you substituted the word Invokana with hydrochlorothiazide or with Lasix. It's a diuretic. Now, the makers of SGLT2 inhibitors worldwide brought these drugs to market because they reduce glycemia. But in fact, you could just as easily say that these drugs are diuretics that happen to lower blood sugar. It depends completely on your perspective. So these drugs are mild diuretics, make no mistake. So it should come as no surprise that patients who are put on a mild diuretic might develop symptoms related to being on a mild diuretic. And so specifically, patients who are also on a loop diuretic, which is another diuretic, or patients who are on an ACE inhibitor or angiotensin blocker, which are drugs well known to synergistically lower blood pressure with diuretics, if they're on those drugs, you have to be cautious. So these things really should come as no surprise whatsoever. And in fact, instead of sort of viewing this as sort of panic or source of panic for this drug, it really should just be a way to inform us how to use it properly. That if you're going to be using a drug that has mild diuretic properties, make sure you have a look at what patients are taking and introduce it accordingly, either with caution or by removing other drugs that maybe have no value. So, for example, if a patient is on hydrochlorothiazide or a loop diuretic and those drugs are not there for any specific reason other than, let's say, lowering edema or lowering blood pressure, remember that diuretics have no specific endpoint advantage. Diuretics do not save lives in the sense of a specific drug property like ACE inhibitors and ARBs have been shown to save lives and protect the kidney. Diuretics don't do that. Loop diuretics and thiazides don't do that. So if you had to reduce a loop diuretic or a thiazide diuretic when putting patients on Invokana, there's no problem with that because they just need less of their other diuretic. Their other diuretic doesn't also lower sugar. So if I had my choice of a drug that did three things, lowered weight, sugar, and blood pressure, versus a drug that just lowered salt and water retention, then I would clearly opt in favor of being on more Invokana, maybe less of a thiazide diuretic. So when these drugs were coming to market originally, and I was doing some talks on them, I used to recommend that as we're learning more and more about them, and we're starting to use them, consider reducing or even removing the dose of diuretics that patients are taking when starting these compounds. If you overshoot the mark, in other words, if you took them off or reduced the dose of the diuretic and their blood pressure rose as a result, you put it back. Blood pressure is a marathon, not a sprint. So if blood pressure went up by a few points, which is all it's going to be by taking away the diuretic or several points, you put it back. But remember that if you're starting them on a diuretic and they're already on one, maybe you could reduce the dose of the one they're on.
I think it'd be great if we could, based on all what you said, just maybe go to this slide.
Sure.
The renal safety and then the credence.
Okay, so I'm just going to, in the interest of time, because I went on too long, as I usually do, I'm just going to skip ahead to these slides here. So I can just, maybe just start with this. Sure. Okay, so does SGLT2 inhibition adversely affect the kidneys? Remember, the only way to answer that question is to do a 5-year study, or 4 to 5 year study, 3 to 5 year study, some long-term study. But in the short term, do we have any concerns that SGLT2 inhibitors adversely affect the kidneys? The way to answer that question is to look at two major tenets. One is the GFR and one is the ACR. But remember, GFR is hard to interpret in the short term. So in terms of basic principles, should we expect these drugs to be nephrotoxic? Well, not from the point of view of the glucose itself. So tubular glucose should not lead to any change in the effects, the typical effects of diabetes on the kidney, because when diabetes harms the kidney, it does so because blood sugar is high, not because tubular sugar is high. It's because blood sugar is high. And so we should not expect any damage to the kidney as a result of tubular glucose like we would when you have higher blood glucose, like in the setting of diabetes. So tubular glucose should not have any impact on renal health per se. And as we know, patients who have renal glycosuria, which is a condition where patients are on endogenous SGLT2 inhibitor, basically, they have no increase in renal events. So the drug itself should not cause anything related to the sugar being lost in the urine. But what about other effects? Well, as we pointed out before a few minutes ago, the changes in GFR are very small and could be likely attributed to volume shifts, and we don't know if any of these will ever continue to be negative as you move past the 26 weeks, and there is a distinct possibility that the reduction in GFR, like it is with ACE inhibitors, is actually protective in the kidney itself. What is the other way we can judge whether the kidney is being affected adversely or not? The other one is proteinuria rising, because proteinuria is the hallmark of diabetic damage. Well, if anything, it's the opposite. So again, these are short-term studies, but what they found with SGLT2 inhibitors, with CANA specifically, is that when you put patients on it, the amount of albuminuria that they had, even though they started with small amounts of albuminuria, went down. So that, to me, is one of the most important markers that the kidney vis-a-vis diabetic damage is actually getting better, theoretically, or certainly not getting any worse. And patients can progress from different stages of albuminuria, so none to micro, micro to macro. That's progression. The more progression you have, the more diabetic nephropathy you're presumed to have. And patients who were put on SGLT2 inhibitors, in this case CANA again, the degree to which they progressed was lower, and it actually, interestingly, was lower with each successive dose of CANA. So CANA 100 led to a 9% change in albuminuria level, and in a dose-responsive way, it seems, CANA 300 led to a further reduction in progression of albuminuria. So from a GFR perspective, I don't think there's any concern that we can see, and in terms of albuminuria, there may be some protective effects. And the last thing I want to leave you with is this, that because this purposeful, almost, reduction in GFR might actually be a good thing in the long run, people who make SGLT2 inhibitors, and Janssen is not alone, are actually onto this and realize that not only are these drugs potentially safe for the kidney, but they actually may be specifically protective of the kidney. And the only way to prove that is to do a long-term study. So there is actually a study under enrollment already called the Credence study. It's a Janssen study. Other companies are probably doing the same thing. And it's a phase 3 randomized, double-blind, placebo-controlled, parallel group trial enrolling 3,600 patients, which is a big number. And if I recall correctly, I think the follow-up time is 3 years. And it's a simple question. What happens to hard renal outcomes, doubling of creatinine or ESRD, end-stage renal disease, in patients put on these drugs? And is CANA not just safe, but actually protective of the kidney in the long run? So the last thing I just want to leave you with, the main message I want to leave you with is not to overinterpret some of this data. I think that SGLT2 inhibitors are an extremely safe class of medications, extremely well studied, and any of the concerns related to adverse renal events, that is changes in creatinine or changes in ECS volume or symptoms of volume contraction, are mild and can be explained by concomitant therapy, that is with ACE inhibitors or ARBs, or loop diuretics, and that theoretically, when starting these drugs in those combinations, you have to be cautious, but not in a different way at all that you would be if you were to start patients who are on ACEs and ARBs on low-dose thiazide diuretic, for example. So I don't think that these should come as any surprise, and I think that the effects are explainable, and most importantly, I think they're mild. So I think with that, we'll pause.
So are there any questions? Thank you so much for your presentation. Are there any questions from folks on the line?
I have a question, Dr. Weinstein. First of all, that was absolutely fantastic. It was extremely informative, so thank you so much. My question for you, that's probably one I should already know the answer to, is the different doses of ACE and ARBs. I know we have discussion where we say, think about cutting back on diuretics or ACE and ARBs. Is that an easy thing to do? Is there a lot of range in terms of different doses, and then the combinations with hydrochlorothiazide as well?
This is a really important question. It's important because this is what I was alluding to. And if you were going to go and tell people that, you have to be very careful with your wording. The reason is that people believe that ACEs and ARBs are sacred for very good reason, because they are. And also there is data to suggest that dosage of ACE inhibitors and ARBs matter, not in terms of the effect on blood pressure, but in terms of the cardiovascular protection. So if you go and say, use my SGLT2 drug that I'm promoting, just reduce the drugs that you've been using for the past 10 to 15, 20 years, and you'll be okay. They may not, that may be met with a raised eyebrow or two. So I think the point there would be, I would actually err on the side of suggesting more so reduction in diuretics, other diuretics versus the ACE or ARB, only because diuretics are not sacred. They have no specific value other than the fact that they lower blood pressure. But leeches would have the same value as diuretics, really, in terms of lowering blood pressure and value. It's just that leeches are not popular anymore. But diuretics have no specific endpoint advantage. So I'm quite comfortable recommending that people should reduce or sometimes even eliminate the mild diuretics they're taking, because guess what? They're now on another mild diuretic that has other interesting properties that probably are more attractive than the thiazide properties are. So I think that I'm much more comfortable advocating a reduction in diuretic dose. In terms of the ACE and ARB dose, maybe I wouldn't use it. The term I wouldn't use is, or the approach I wouldn't use is to suggest people reduce the doses of the ACE or ARB, but just that if they are on, let's say, a dose of ACE or ARB and they're very close to their blood pressure target, or let's say they're well below their blood pressure target, which often happens, then those patients should be treated with SGLT2 inhibitors with caution, because their blood pressure will fall. A good example I'll give you is a patient with diabetes who's on 10 milligrams of Altase, and his blood pressure is 110 systolic. If you put them on an SGLT2 inhibitor, their blood pressure may drop. And you know what? It may be that an SGLT2 inhibitor is not ideal for that person. Fortunately, the extremely well-controlled blood pressure in a diabetic is on one drug is not common. And more commonly, you'll see a patient who's on 10 milligrams of Altase, but also 12.5 milligrams of hydrochlorothiazide and 5 milligrams of amlodipine, and maybe even something else, in whom SGLT2 inhibitor is being considered. If that person was being considered and their blood pressure was as low as that, I would say, you know what, why don't you consider holding the hydrochlorothiazide, and then if you need to add it back in future, you always can. So I think that your point that you raise is an extremely important one, because I don't think it should be the company's or anyone's position that we advocate reducing the dosages of things that have been really the backbone of managing patients with cardiorenal disease, but just to be aware that they're the ones who might experience the side effect most if their blood pressure is extremely well controlled.
Excellent. Thank you.
Dr. Weinstein, I had a question for you. I know a lot of my speakers are basically saying the same thing, to pull back on the 12.5 of hydrochlorothiazide when the SGLT2 is brought on board. The one question I had is, sometimes with the ACEs and ARBs, we know that they throw potassium back in the system, and a lot of them feel that this is mitigated through using the combination medications with hydrochlorothiazide. And I've had a few questions about, if we take that hydrochlorothiazide out and now add in your medication and we're adding more potassium into the system, is this potentially going to be an issue?
This is another good question. So the issue of hyperkalemia has come up with these drugs, and I've looked at the data. So first of all, I won't address your question just yet, because it actually gets worse with what I'm about to say. That there is some concern that in a analysis of some of the CANA data, that you get very, very slight rises in plasma potassium when taking the medication. And I have to say that it's not intuitive why that would be, because these patients are increasing their distal delivery of salt, and they should, if anything, develop some hypokalemia, but they do not. So we're not exactly sure why that is, but what we can say is that the magnitude of potassium rise is very, very small. But related to your other question, which is very important, is you're right. A lot of people like the added value of the hydrochlorothiazide to maintain potassium in the normal range. So what I would say to that is those patients, again, might not have to come off the hydrochlorothiazide. In fact, most patients may not have to come off the hydrochlorothiazide. The patients that will are going to be the ones that are at or well below their blood pressure target and may not need it. And they may not need it for potassium lowering, but more importantly, they may not need it for blood pressure lowering. So I'm not saying that everyone should be removed that everyone on hydrochlorothiazide should be taken off when put on an SGLT2 inhibitor. But the group of patients whose blood pressure is very well controlled on the HCT add-on, you might consider when starting the SGLT2 inhibitor either reducing or removing it, unless they did have a significant problem with hyperkalemia in the past, in which case you might want to leave the HCT on board. It's very hard to make a blanket statement for all because it's complicated, but I think that there's no doubt that you might get pushback from people that use HCT on board with an ACE inhibitor to maintain potassium in the normal range. And in that case, this line of recommendation will not work, or maybe it's not ideal for that patient. But I think for many patients who don't depend on hydrochlorothiazide to keep their potassium in the normal range, for many of those patients, they're not going to miss being off the hydrochlorothiazide. But your question is a very, very good one because you will get pushback on that. And I think that it's a fair point. It is a fair point. But also remember that there are going to be an enormous number of patients who are on hydrochlorothiazide who don't use it for potassium control.
Perfect. Thank you.
All right. Thanks so much, folks. I'll pass it over to Eric just to close because we are a little bit over time and want to respect Dr. Weinstein's time as well. Eric?
We did it. Yes. So certainly thank you so much, Dr. Weinstein, for your time. I know that we're over. We're on overtime mode right now since it's already nearly quarter after. So I certainly thank you so much, everyone, for joining today and taking time out of your schedule. And hopefully this did add a lot of clarity to a lot of the things that are in our product monograph, but just other things that we as a diabetes company now need to know, and our customers expect that we know this. So there'll be future educational series around this type of topics, and certainly if there's any future questions or questions that were not answered that you would like answered during this teleconference, please feel free to email myself, and we'll get answers for you. So once again, thank you so much, Dr. Weinstein, for your time today, and I look forward to seeing everyone soon. Thank you.
Bye.
Bye-bye.
Thank you.